series of CAHO and ISQua, the International Society for Quality. Today, we have with us a very, very important topic close to everyone's heart, I must say. We are going to be talking about patient safety. And we have with us today the moderator for the event, Dr. Rahul Deshmukh. This is the 51st webinar series of CAHO and the International Society for Quality together. It's on patient safety incidents, reporting, learning, and creating the safety culture. To mention about Dr. Rahul Deshmukh, he's a very experienced and innovative medical director and chief anesthesiologist with over 25 years of clinical expertise and over a decade in leadership roles within JCI accredited hospitals. He's also an international consultant for the Joint Commission International, and he contributes to improving global healthcare quality standards. He collaborated with CAHO and has been part of the 17 studies that we did together, the patient-reported experience measures, and he's also part of the PROM study on spinal anesthesia. I must thank Dr. Rahul Deshmukh for introducing the concept of patient-reported experience measures to India. Today, it has become part of the NABH accreditation standards, and we, along with Dr. Rahul, have been part of developing the 17 patient-reported experience measures, and we have published the white paper. So he's a good friend of CAHO, a person who's committed to quality and patient safety. And Dr. Rahul, I hand over the stage to you. Please take over, introduce the speaker, and the stage is all yours. Thank you for accepting our invitation. You're on mute, Dr. Rahul.
Thank you. Thank you, Dr. Lalo, for all those kind words. And let me compliment as well as congratulate CAHO as well as ISQua for this wonderful initiative. It's a great learning opportunity for everyone. I know there are something like 800 or 1,000 registrations for this webinar itself. I could see some people sitting in an auditorium. This is the specialty of CAHO as well as ISQua, that we create learning opportunities for the members. Coming to the topic for the day, incident reporting, as Dr. Lalo was saying, it's close to everyone's heart. That's the core of patient safety and improving quality. As we say, failure is the greatest teacher, and we only fail if we don't learn anything from that failure. Incident reporting is something very similar to that. Incidents will happen as long as we continue to work, incidents will happen. It is important that what we learn out of those incidents, that is the most important thing. And that's where we can identify the loopholes and mistakes that happen in our systems, and that's how we can improve. And to speak about it, we have a fantastic speaker today. Dr. Elom he's a world-renowned authority in patient safety and quality. He has worked with many international organizations like the United Nations Development Program, World Health Organization, UNICEF, to name a few. He has been instrumental in developing the culture of quality and patient safety in many African countries, particularly Ghana, Liberia, Namibia, Democratic Republic of Congo. He has also been an avid researcher in the field of quality and patient safety. He has published many articles. He also has a keen interest in the non-communicable diseases. These are the two key areas these days in healthcare. One is non-communicable diseases, and second one, of course, is quality and patient safety. He also has been a member of the ISO technical committee, which develops the ISO standards, and he's a fellow of ISQua, very rich academic profile. He's a PhD, he's MPH, he's as well as MA. So I think the right person to talk about this issue of incident reporting and developing the culture of safety. I think I'll hand over the mic to Professor Elom, and he can take it forward from there. The presentation will be followed by a question and answer sessions. If there are any specific questions that you would like to ask the expert, you can type it in the chat box or chat in the group chat, and we'll take it forward from there. We'll be selecting a few questions and take it forward from there. Thank you so much. Over to you, Dr. Elom.
Thank you. Thank you very much and for the opportunity, CAHO. Yeah, so the topic already has been introduced. So this is a brief outline given the time that we have. So the first thing I would like us to see is, where does patient safety fit in the entire quality discussion? Now we see that healthcare quality, according to the Institute of Medicine, is the extent to which health services provided to the population increases the likelihood of desired health outcomes. And these are also consistent with the current professional knowledge as far as the providers are concerned. Now, if we look at the IOM, there are 6 quality dimensions, but these have been expanded in the WHO's publication and in another publication by Crook, and they add integrated and integrity to the quality dimensions. So we see the centrality of patient safety. I mean, the quality dimensions on its own can be another whole level of discussion. I mean, timeliness is the extent to which we provide care without delay. Efficiency is the extent to which we provide care by ensuring that there is little or no waste. Effectiveness is the extent to which our outcomes are met. Integration is the extent to which care is provided in a one-stop shop manner. Integrity is the extent to which we provide care devoid of corruption and collusion. People-centeredness is the extent to which we provide care by respecting the patient and treating the patient as a human being. And equity is the extent to which care is provided devoid of discrimination. And to our discussion point for today, safety is the extent to which care is provided devoid of harm. So if we look at this is the WHO's publication, the Global Patient Safety Action Plan, which is gathering, or all of us are rallying around as far as the patient safety effort in each country is concerned. And in this document, this is the definition of patient safety, that it is a framework of organized activities, and these activities create cultures. They create processes, procedures, behaviors, technologies, and the environment in healthcare. And this is consistently and sustainably. And this ensures that there is reduced risk, there is reduced occurrence of avoidable harm or preventable harm. And it also ensures that errors are less likely to occur. And its impact, even if they occur, is also reduced to the barest minimum. Now let's look at some statistics when it comes to the burden of unsafe care. And this data is also available in the websites and in the references that I have provided. We know that 1 in 10 patients are harmed. Some literature even say when you come to lower middle income countries, this is even up to 40% from the 10%. And 3 million deaths are also occurring annually from unsafe care. 10% of adverse events occur in the surgical settings for those of the colleagues who are in surgery. And we also see issues with sepsis, that about 23% of healthcare-associated infections are contributing to sepsis. And we see diagnostic errors. Up to 20% of doctor-patient encounters will result in diagnostic errors. 134 million adverse events in hospitals, and 2.6 million of these deaths occurring in lower middle income countries. And it is also cost and money to hospitals and the whole healthcare institution. I mean, we see that in some settings, it is contributing to about 15% of the hospital expenditure. And this amount can be used to expand the hospital, expand services, infrastructure, and other aspects of care. If we go to the NHS, it contributed, the NHS paid about 1.63 billion pounds sterling only on litigation. And I know in our various countries, we are grappling with litigation and issues of medical legal issues as far as our healthcare is concerned. And again, in another setting, 1.4 trillion US dollars was also spent, or is spent also annually, and is lost. And the interesting thing is that up to 80% of adverse events are preventable, or up to 80% of the incidents that lead to unsafe care is preventable. And I see that also in my own publications that was done in Ghana. So let's look at some of the common adverse events that are likely to happen. And we know these diagnostic errors, unsafe surgical procedures. In one hospital, a patient was taken to the theater. They opened the head up for a neurosurgery operation, opened the head up only to realize that this was the wrong patient. So they closed the head, pushed the patient back to the ward, and they were now looking for the patient who had to be operated upon. Issues of healthcare-associated infections are plenty, medication errors, blood transfusion, unsafe transfusion. I traveled again to one country. As we walked through one of the pediatric wards, a patient was just shaking on the bed, and then we stopped the transfusion only to see that it was blood incompatibility. And then there are issues with patient misidentification, patient falls, which is occurring frequently, and pressure ulcers, which sometimes result in bed sores. So this is some data from one facility as far as their patient safety incidents and reporting is concerned, some of the events or the incidents that they are documenting in that particular medical department. So we see that patient safety represents a tangible manifestation of realizing health-related human rights, and it's a litmus test of the global commitment towards respecting, protecting, and fulfilling those rights. So patient safety is a right, and it's elevated to the human right. And consistent with this, the WHO published the Patient Safety Rights Charter, which identifies a number of patient safety rights as far as our healthcare is concerned, and which every patient is entitled to. And I wish that we will all do just a Google search for this document, and you can download this document, and it can guide you as far as your practice is concerned. So what is patient safety incident reporting then? We say that is the process by which healthcare providers and even patients document and report incidents or events that have the potential to cause harm, or harm has already happened to the patient through patient safety reporting systems. So this is key, that we document. It helps us to document that when there are potential to cause harm, the harm has not yet happened, there's a potential to cause harm, or the harm has happened, so that you are able to document. Now, key is that our reporting will have to be timely. When the event happens today, we don't wait to document the event tomorrow or 3 days after the event has happened. The event has to be accurate. We should document what exactly happened and not what we thought had happened or what we feel happened, other than what exactly happened. And then secondly or thirdly, the event has to be as comprehensive as possible. We provide a narrative of what exactly happened, how it happened, so that it can assist us in our investigation. Now, this is another facility when they introduced a reporting system, and how the reporting system improved or increased over a period of time. And you are seeing over a period from 2020 to 2023. So when we introduce a system, we should be patient, because reporting will not immediately happen because of the culture, which we will be discussing in subsequent slides. So question is, what are some of the approaches to incident report, patient safety incident reporting? So broadly, there are some mandatory and voluntary reporting. So, and for each of the reporting processes, the reporting can either be manual and paper-based, or it can also be electronic based. So mandatory reporting is when we are required to report. The provider doesn't have a choice when the incident happens than to report. So that is the mandatory reporting. And the voluntary reporting is when the provider chooses to either report or not report. When it is mandatory, you don't have any discretion to exercise when the incident happens. You just have to go to your system and then log in the incident, or pick your pen and paper and then log in the incident. So these are some broadly what happens. Normally, the mandatory reporting is backed by statutes, or it is backed by policies as far as the organizations are concerned. Some organizations or some healthcare facilities don't have anything as far as what their patient safety policies are concerned. So when the event happened, the providers either decide to report or not to report. So we can look at this. And the question I ask is, what type of reporting systems do we have in our health facilities, and how are we utilizing it? So you can share your thoughts in the chat. And how important is reporting? I mean, super important, because these are some of the importance. It helps us to detect the patterns of incidents in the facility, like I showed you in one facility. And it has, in some countries, there is a legal obligation, and it becomes a legal responsibility. And we also owe it a duty ethically as healthcare providers to report. I mean, if an incident happens, there is a wrong side surgery, or there is a medication-related harm, it is ethically appropriate to report, and you are ethically responsible to report, because you see and know that, I mean, it flies in the face of your Hippocratic oath, which is to do no harm. So we have to report. And reporting in some jurisdictions is also compliance with regulations. As I mentioned, that some statutes require that we report. And it's also important for learning. And it gives us an opportunity to also improve upon our processes in our healthcare organizations. And the other question I ask is, what are some of the challenges to reporting? And we know in some health facilities, there are absence of reporting systems, whether the manual process or whether the electronic processes. So it becomes very difficult even to report when the incident happens. There are also instances of underreporting. I mean, a lot of the times in some health facilities that we know, sometimes when the incident happens, the clinicians will scribble it in their medical records. So, and it is not logged in the registry, so you don't know. And when you start your count, you see that you have underreported. In one facility I visited, there was a scar on a neonate. This neonate was delivered through a cesarean section, and there was a scar. So you saw that there was plaster on the scalp, but this had not been logged into the incident reporting system, but it had been scribbled in the medical records of that particular patient. So obviously there would be underreporting. And we know there are time constraints. There are also issues with lack of standardization in some facilities. And some providers also get scared of what the data is going to be used for. Are we going to be punished if we report? What is going to be the repercussions if we objectively report? So there is some fear of the objective use of the data should we report. And obviously in some settings, there are also lack of resources for reporting. So let's look at learning. What is patient safety learning? And this is the process and practice by which healthcare organizations like yours and mine, we identify the causes of events, and then we implement strategies to avert any future occurrence. So when we report, we will have to learn from the reports we have made. So we identify what the causes of the incidents are, and what strategies can we put in place. So typically, your incident reporting or patient safety learning will include your root cause analysis. It would include your failure mode effect analysis, and any other problem-solving methods that you might have in your health facility. So again, why is it important for continuous improvement? It helps with our evidence-based practice. I mean, it's because of the patient safety learning. That is why health systems have been charged to use checklists, because we see that there is evidence in the use of checklists that it helps us to improve outcomes. Again, it helps ensure trust in the healthcare system, and also improves patient satisfaction and even provider satisfaction. And more importantly, but not the least, is about accountability. I mean, oftentimes we think that some of us preach a just culture, and we think we can run away, we can hide behind a just culture and cause harm or not provide quality healthcare. But it helps us to be accountable. One, to the patient; two, to the healthcare system that we are working within. And the other thing that I want to ask is, what are some of the key strategies that we can employ when it comes to patient safety learning? And I have mentioned some of these already. And I don't know how many health facilities are doing root cause analysis when your incident occur, or the failure mode effect analysis. The other important strategy has to do with training, but we don't have to end there. There is also the need for simulation. And we see a lot of simulation in aviation and in other highly reliable organizations. So we will have to be able to simulate, create instances and scenarios within our healthcare organizations where providers can be able to practice and then mimic various scenarios so that they are able to overcome some of these events whenever they occur, or know what to do in the instance that these events occurs. So again, some challenges we see in some facilities. When we report, we see that there is inadequate analysis of the incident. Sometimes we don't even analyze the incidents at all. So there is no learning as far as the incidents are concerned. So you will realize that if you do an analysis of a particular cause of death, you can tell that it's about the same incident has resulted in one particular outcome over a particular period of time. And this can immediately tell you that these guys or this facility do not have a learning system in place as far as their adverse events are concerned. And I mentioned resource constraints, and there are also cultural barriers. I discussed culture I discuss this in some more details when I am looking at culture. So what is patient safety culture? And what I have here is that it's about values, it's about beliefs, and it's about behaviors that exist within our healthcare organizations. And if we say patient safety culture, then it is these values, beliefs, and behaviors prioritizes patient safety, and it fosters a climate of trust, fosters a climate of openness, and fosters a climate of continuous improvement. So that is key. And I mean, a strong safety culture, or what has become known as a just culture, will often support reporting of incidents. It will encourage learning, and it will ensure that patient safety is consistently prioritized in all our settings and care environment. So that is key. Now, let me quickly talk about this, that there are 3 levels of organizational culture in healthcare. So if you enter any healthcare organization, there is the culture, the things that you see people are doing, which is very visible. And there is also the SAP, which is the shared ways of thinking, which we use as a justification for some of the practices that happen. And there are the deep things, which is the very sub, which are the shared assumptions, that some of the practices we don't talk about it, but they are the things we do. Some of the practices, it's like haram. If you talk about it, it's like a taboo, but it informs our shared ways of thinking, and it obviously manifests into some of the things that we do within our settings and our organizations. So there are 3 things I identify that either build an organization's culture or they kill an organization's culture. And one is the symbols. The other is the attitude. how we do things in the organization, the attitude of the providers, the attitude of the care providers, and the patients, how the system is designed forces the patients to also behave in a certain way. I mean, in some care settings, it is an abomination for a nurse to correct a doctor. It is an abomination for a house officer to correct a consultant. So, I mean, some of these practices, so that even when the consultant is wrong, everybody puts their hands at their back and watch the consultant because it is an abomination. So the symbols, the symbolism, the attitudes, and then the other is the processes and the care systems. How is healthcare organized within that particular hospital? I mean, most organizations, do you always have to go to the OPD or the outpatient department? Do you necessarily have to go to the outpatient department? In some organizations, even when it is an emergency, you necessarily have to go through the outpatient department process. So our processes, our systems, and how they are organized, all of these will either enhance or build the organization's culture, or it will kill the organization's culture. And when you enter any healthcare organization, you can just look at how these three things play, and you can tell what sort of culture exists or does not exist in that particular organization. So these are some of the key characteristics of a positive patient safety culture, or a strong patient safety culture, where there is open communication. We talk about patient care. There is leadership commitment, which is very visible. Leadership support and commitment, which is very visible. And here, leadership, I'm talking about positional leadership and functional leadership. So the positional leader is the head of department, the CEO, the head of nursing, the director of nursing. And then the functional leader is the nurse at the front end, the laboratory scientist at the front end, or the doctor at the front end. And all of them are super committed, especially the positional leader, because it's the positional leader who will have to ensure that the resources we need to enhance patient safety are available, and the symbols and all the right attitude is also cultivated amongst the providers. And obviously, teamwork and collaboration. Teamwork and collaboration is where every provider realizes that I cannot do this alone and all by myself, but I require the services and the involvement of other colleagues as far as this patient care is concerned. And the patient-centered approach, which is ensuring that there is respect, collaboration, and the patient is dignified as far as the care we are providing is concerned. So, I mean, these are the benefits of a patient safety culture. We see there's improved reporting, enhanced patient outcomes. I mean, your mortalities will reduce, there will be improved adherence, and staff morale and retention is improved. And these are some of the challenges similar to the challenges with reporting and learning. And then some of the key barriers to establishing a patient safety culture. I mean, ego, and lack of humility to learn, especially, and this is very prevalent amongst the physicians, the physician team, and a lot of studies attest to that. But there are also a lot of other team members who are also super full of ego and lack the humility to learn. So when there is a correction, they are mindful where it is coming from. And I mean, woe even betides you if it is a patient. We'll ask you, when I was studying in school, when I was in practice, where were you, and etc. And there are issues of trust. At the healthcare system, there are challenges with trust and trust issues. There are the issues with the siloism and thinking in parts, which defies the key, one of the key quality dimensions of integration. Doctors who are seen to be working alone, nurses are alone, lab scientists are alone, even anesthetists are alone, surgeons are alone. And I mean, we work in cracks and silos, and it defeats an improved patient safety environment, and it makes care very unsafe for our patients. And excessive political interference, which is either partisan or power play in the organizations. And some of these also makes it difficult for the key actors to take critical decisions in the organization, because it can be overridden by the powers that be, and lack of congruence, which also speaks to the siloism, and leadership, which I have already mentioned. So I am ending with what I published in one of the ISQua blogs as my 10 commandments of patient safety. And I believe that these will enhance a just culture, or a patient safety culture, and ensure that there is learning and improved reporting. And the first commandment I have is that thou shalt be authentic and genuine, other than being fake, false, and deceptive. So as healthcare providers, we have to be real, and we have to be ourselves. We have to be very authentic as far as our dealings with our colleagues is concerned. And this is one of the key things that would enhance trust amongst us as providers. My second is, thou shalt show compassion and care, other than cruelty, disregard, recklessness, and lack of attention. And this speaks to the heart of patient-centered care that you saw in one of the slides. And it also speaks to the heart of patient safety, that thou shalt do no harm, as far as our Hippocratic oath is concerned. My third commandment is, thou shalt collaborate and work together, rather than competing and undermining one another. This speaks to the heart of teamwork and collaboration, which we saw in another earlier slides. And my fourth commandment is, thou shalt be inclined to emotional intelligence, other than intelligent quotient. All of us are nurses, doctors, anesthetists, biomedical scientists, because of our high levels of intelligent quotient. But in addition to our IQs, we need emotional intelligence, which is our abilities to adapt, our abilities to be empathetic, our abilities to show concern to the patient, and all the things that Daniel Goleman talks about, all the competencies that Daniel Goleman talks about. My fifth commandment is, thou shalt integrate and coordinate. My sixth to 10th commandment, my sixth commandment is, thou shalt confront and speak up. We should be able to speak up to patient safety. I was in one facility. I don't have a lot of time, so I am limiting the stories. In one facility where there was an issue, and I asked that, if this patient was your relative, is that how you were going to approach the care? And the healthcare provider was like, as for my relative, the care I will provide is different. So we should be able to speak up. I mean, if irrespective of our levels and our hierarchy, when there is a wrong, we should be able to speak up. And in aviation, this is done very nicely, that it doesn't matter where you are in the chain. When the pilot is wrong, you should be able to approach the pilot, because if you don't speak up, the aircraft is going to crash and all of us are going to die. So we should be able to speak up. If we have our consultants, our nursing heads, whatever, we should be able to speak up wherever we are. And we should also encourage patients to speak up. And we should be able to confront. It says, thou shalt confront and thou shalt speak up. And confrontation is not negative confrontation. And then my seventh commandment is, thou shalt be expressive of your feelings, other than bottling up. When we have to cry, let us cry as healthcare providers. When we have to laugh, let us laugh as healthcare providers, other than always bottling up. And sometimes we bottle up and bottle up and bottle up. And then one day at meetings and in boardrooms, like we are seeing, we explode. And I mean, what good does it serve the patient and the system? So thou shalt be expressive of your feelings, other than bottling up. And my 8th commandment, thou shalt embrace continual learning, other than blaming and shaming. And we have spoken about learning. And I charge all of us that we establish learning systems, which even goes beyond patient safety, so that we shall establish systems where we can learn. We learn from the events that occur, so that we put in place mechanisms to avert future occurrences. We should eschew the needless blaming and the needless shaming of colleagues who inadvertently cause the patient safety events in our respective health facilities. And my 9th commandment, thou shalt embed human factors and ergonomics. Let us design our processes and systems around people, and let us be considerate about the fallibilities of the healthcare providers that we are working with. And that is what the auto industry have done for us. So in some cars, these new generation cars, when you sit in some of these cars and you pull to drive, you cannot start the car. And when your car is on drive, those of us who are still using key, when your car is on drive, you cannot pull your key from your ignition. And those of us who are using keyless cars, when your car is on drive, you open your door, you will be hearing the beeping sound continually, which serves as a reminder that there is something wrong. You will have to check. And that is human factors and ergonomics. And that is what we should be factoring in our designs, so that we will not only be relying on the intelligence and memories of our healthcare providers as far as their practices is concerned. And my 10th and last commandment is thou shalt love. And when we love, and I will sum up that with a statement Don Abedian made in a jiffy about love. So the other way forward that I propose is that, one, as healthcare systems, we should be humble to admit that things do not always go well as expected. We should admit that errors are inevitable. And we should also note that to err is human, so that we shall design to address all of these fallibilities. 2 is that we should establish robust reporting systems that allows us and our healthcare organizations to identify risk, and also enables us to learn from these mistakes. And thirdly, we should integrate and facilitate the integration of patient safety into various national health policies. I mean, in Ghana and in a lot of African countries, we have patient safety integrated into their national healthcare quality strategies, and which countries are implementing. So we should encourage same across our various countries and in our respective healthcare facilities as well. And 4 is that I propose that we avoid or reduce the legal and adversarial system, where whenever event happens, we are in a hurry to go to court, and patients are in a hurry to take us to court. I think that we should adopt a quality improvement approach, which enables us to learn from events when it occurs. We should facilitate the establishment of quality management units in our respective ministries of health and health facilities. And we should also establish various ethico-legal departments, not only legal departments, but ethico-legal departments. We include the ethical aspect of patient safety, which we have seen, together with the legal issues of patient safety, so that when the events occur, we are looking both at the ethical implications and the legal implications. And when that happens, we can be humble enough to admit that we erred and call the patient's relatives or the patient to the table and have a discussion, other than always going to court. And sometimes the legal cases are endless. And the 5th I propose in this is that our ministries of health and health facilities, we should establish dedicated funding so that we can compensate victims of adverse events including providers, because oftentimes providers also become second victims when these adverse events occur. So we should consider putting some monies in our national health budget and in our health facility budgets so that providers are compensated and then patients are also compensated when adverse events occur. And then last but not the least is that we should prioritize the building of a strong patient safety culture in our healthcare facilities, which encourages reporting, which ensures that every incident is treated as an opportunity to learn and improve as far as our healthcare organizations are concerned. And I end on my 10th commandment, and picking this from Donabedian's reflection, that we should always remember, as Donabedian reflected, that healthcare is a sacred mission. It is a moral enterprise and a scientific enterprise, but not fundamentally a commercial one. Donabedian says that you and I, as healthcare providers, we are not selling a product. You and I, as healthcare providers, we don't have a consumer who understands everything and makes rational choices. And he included himself. He says that doctors, nurses, pharmacists, lab scientists, whatever your profession or career is, administrators, we are stewards of something precious. And I believe that precious thing is the life, is the patient who sits in front of us daily. So he says that ultimately, the secret of quality is love. You and I will have to love our patients. You and I will have to love our profession. And you and I will have to love our God. Whatever God that you worship or whatever God that you pray to, you and I will have to love that God. And he concludes again by saying that if you and I have love, then you and I can always work backwards to monitor and improve upon the system. You and I can always establish all the appropriate systems as far as the care is concerned. And you and I can always ensure that we are providing care that meets all the 8 dimensions, including patient safety. So I think that is my final slide. These are some references that I used, and thank you very much. I'm happy for some discussions and comments. Maybe that can help me share a lot of the stories that I couldn't share. Thank you. All yours, moderator.
Yeah, sure. Thank you, Dr. Elom. What a wonderful presentation we had. I was going through some messages that have come. Thank you so much for the presentation, Dr. Elom. Fantastic slides and very well explained. You did not only start with what is the sort of where does the patient safety fit into the whole culture, but also the highlight of the presentation, probably in my opinion at least, is the 10 commandments that you shared. Amazing, amazing. Really happy that I could moderate this session. There are a few questions. I think some people have raised their hand. We'll go in order of raising their hand. Let's see if they have any questions. Please, you can go ahead with it. Bindu Subhash. If you have a question and if you have raised your hand, please ask your question, or otherwise you can type it in the chat box also and we can share it from there. All right. In the meantime, Dr. Elom, I would like to understand the role of triggers. IHI has come up with the concept of triggers to uncover underreporting of incidents. What is your take on that? How the triggers can be used to see whether incident reporting is happening properly, or are there any underreporting of incidents?
Yeah, so I think the patient safety triggers are some of the many tools that healthcare institutions can use when it comes to reporting patient safety and even identifying patient safety and the patient safety situation in our healthcare organizations. So I think the triggers is a complement, but we should not substitute the triggers for maybe analysis of the incidents when they occur. So it helps us to know our system. It helps us to identify the possible patient safety situations in our system and how we should also be acting on those incidents in the event that they occur. So I think that they are excellent tools. There are various other tools that institutions can develop that can help institutions as far as their patient safety situation and patient safety work is concerned. And I will encourage all of us. This is available free online, isn't it? So all of us can take a download and then see how we adapt it to implement in our respective healthcare organizations. Over.
Yeah, perfect. There is one question which asks about the duration of investigation of incident reporting in your system. Do you have, as you were rightly saying, that it should be reported in a timely manner. At the same time, it needs to be closed in a timely manner. So do you have any sort of duration for closing these incidents or investigating these
Yes.
incidents?
Yeah. So what happens with duration is that for every health system, you will have to have a list of what must be reported. That is one. And then you can also do a severity analysis of your incident. And this should be informed by your patient safety policy. So you do a severity analysis of your incident, so that for incidents that you think are very severe, when they occur, then your timeline can be analysis and investigation immediately. And then for events that are moderately severe, you can also assign a particular time to it. And for events that are less severe, you can also assign a duration and a time limit for it. So that will be the proposition that I will make. One of the first places we can go to is that there is the list. I mean, so it depends. If you read US literatures, they call it sentinel events. If you read other literature, they call it serious adverse events and etc. And some of these events are maybe deaths within 24 hours. Others even have pressure ulcers or bed sores, patient falls, for instance. So for some of these severe incidents, it can be within 24 hours or immediately. And then you can also stagger depending on your list of incidents. So that will be the recommendation that I will make, that you will have to categorize your incidents. If they are very severe, I propose that the very severe incidents are analyzed or investigated maximum within 24 hours. And those that fall into another category of maybe moderately severe, they can be analyzed probably maximum within 48 hours. And those that are less severe could be done probably anytime within 72 hours or 96 hours, which is 4 days. So that will be the proposition I will make. But it depends on your own healthcare setting and environment. Over.
Perfect. Another question is, what is the importance of disclosure in patient safety events? And in this case, what are the patient safety events as disclosure to patients or patient relatives? So basically, it's about disclosure of patient safety events as such.
Yes. So I think that one is that it is a right of every patient. So we shouldn't see disclosure as the health system doing the patient a favor. The patient has a right to information. So in Ghana, we have what we call the Right to Information Act, and it is a right. We also have in our patient's charter, where the patient also has a right to information. Now, for us as healthcare providers, sometimes we tend to play God and decide which information we should share with the patient and which information we should keep. I mean, but patient-centered care trains us and helps us to know that, or the concept of autonomy helps us to know that an autonomy is an ethical principle, which says that it is my body. If I come to your consulting room as a patient, I have to give you permission to touch, and that is informed consent. So if I give you the permission to touch my body and there is anything that happens, you will have to tell me as a form of right. I mean, telling me that I have an abscess, or telling me that I have a second or third degree perineal tear if I am an obstetric patient, or telling me that what you amputated on the wrong leg or the wrong hand, or you gave me a wrong medication. It's not a favor you are doing to me. It is my right. And you, as the provider, it is a responsibility. So, I mean, let us not see disclosure as either or. It is the right of the patient to know. And these are firmly based on the ethical principles of informed consent and autonomy. So, I mean, there is no and the patient and the quality dimension of patient or people-centered care. So it is not either or. So you don't choose which information to tell me. And there is a classical legal case that happened in the UK. Is the Montgomery and the Lakeshare health state, or whatever it is, in the UK, happened in 2015, where a pregnant mother, she was diabetic, and the obstetrician saw that there were implications if the patient delivered vaginally. So the obstetrician did not disclose the implications of vaginal delivery and a cesarean delivery to the woman. And the woman was allowed to deliver vaginally. And the baby later developed a cerebral palsy. And this case was taken to court. Yeah, I mean, and the doctor was saying that she knew that if she had told the patient that when she delivers, if she had made full disclosures to the patient would have opted for a cesarean section. And she didn't want to increase the prevalence of cesarean section and all the odds of cesarean section. So she hid the option of a cesarean delivery, and the patient did a vaginal delivery, and the outcome of the baby was a cerebral palsy. So question, did we go or did we come? So disclosure is not a choice. It is a right of the patient, and it is a responsibility of the provider. So I think that is what we should be taking from this discussion, that you don't have a choice to decide whether to disclose or not to disclose. Thank you.
Okay. Thank you. Thank you. In certain countries, it is mandatory now. By law, it is mandatory that any incident has to be disclosed to the patient. Okay. Being mindful of time, I think we'll take another last couple of questions. One is, after analyzing the root cause, how do you prioritize your action of improvement?
Yeah, so in this as well, there are various quality improvement tools you can use. One is what we call the prioritization matrix. You can also use your graphs, your bar graph or your histogram, for it to tell you which of the incidents are of any magnitude as far as the causation or the outcome or the implication is concerned. And I have also said that you could also use the severity matrix to make a determination. So for incidents that are very severe, I think those should be prioritized in your address. The other is about how many people are affected by a particular incident or outcome. And that can also guide you in your prioritization, which is the basic epidemiology as well, that how many people are impacted or affected can also be used. But otherwise, all the other various quality improvement tools, like your bar graphs or your Pareto charts, your prioritization matrix, all of these tools can also come in handy as far as your quality improvement tools are concerned. Yeah, over.
Okay, I think this is the last one, which spoke about the severity of the incident. Now, there is a question about who decides the category or severity of the incident that happened. So who is the one who decides this, the severity of the incident?
Yeah, so who decides can be your country. That is, if patient safety is in any legislation in your country, then you start from that level, which can be a national legislation or your Ministry of Health. But if you don't have anything in your country, because for us in Ghana, and I have also supported other countries in developing their national quality strategy, we include patient safety, but we don't indicate the list of events and the severity of events. We leave that to the discretion of the ministry. So the ministry will have to then develop some operational policies that would develop those lists of events that are severe. So that is another level. Again, in Ghana, we have our patient safety policy, and in that document, it lists the events and the severity of events and which has to be reported and which does not have to be reported. So if you don't have it at the national level, and then as an institution, your quality department will have to develop one with the support of the management of the institution. So these are the various levels that I propose we can get the severity from. And then if we don't have in our country and our facilities, we can also borrow from best practice, global best practice. But then when we borrow from global best practice, we will have to adapt so that it fits our situation, other than taking it hook, line, and sinker. Because when you do that, it might not work in your setting. So for instance, for me, as I work and travel across the continent, whatever works in Ghana is not a guarantee that it will work in Sierra Leone or Botswana or South Africa. So anytime I am in any of those countries, I adapt whatever best practice I know, and then to see how it works. So adaptation of global best practice is another area where we can get some of these indices of severity from. Yeah, over.
Perfect.
Thank you.
Thank you so much, Dr. Elom, for sharing your knowledge and your experience with us. It has been a fantastic presentation. I can't thank you enough on behalf of CAHO and ISQua both. Thank you so much.
Thank you very much, Dr. Elom, for that wonderful presentation, and Dr. Rahul for the wonderful moderation. I would take this pleasure to invite Dr. Pramod Paharia to hand over the certificate of appreciation to Dr. Elom, please. Dr. Pramod.
Hi. Yeah, good evening. Dr. Elom, it was really nice to hear from you. A topic very close to our heart. And I think, as Sir was also mentioning, incident reports is something which and patient safety is something which is very close to each and every healthcare worker. In the present day and world, we all want to know a lot on this. Such a lucid presentation, very nicely done.
So, Dr. Elom, on behalf of CAHO and all the participants, we wish to hand over this certificate of appreciation to you. It will reach out to you by email. Thank you very much once again.
Thank you.
Thank you.